Welcome to the Menopause and Cancer podcast, where we speak with cancer patients, survivors, and incredible menopause experts to help us find solutions to our symptoms and ideas to improve our health. My name is Dani Binnington, and I'm delighted to talk about all things sexual health with you again today. And I really want to address why it's not enough to just treat our physical symptoms. We've got the amazing Dr. Laila Agrawal on the podcast today. Laila is a board-certified medical oncologist from America. She's done great things with her sexual health clinic where she works, which she will share with us. But Laila explains why it's a really complex sort of issue, and we can't just treat our physical symptoms. We talk about low libido to no libido. We talk about the change in relationships after a cancer diagnosis and the impact that has on our sexuality and on our desire. And then, of course, we talk about all of the treatment options available to you after you've had a cancer diagnosis. Now, about halfway through this podcast, Laila talks about the use of vaginal estrogen after breast cancer, specifically for those on aromatase inhibitors. So if anyone is a bit worried or unsure, or you've had conflicting advice, we will share all of the big statements that has their guidance that has come out in America and most recent updates. And so flick through that if you haven't been affected by breast cancer, but do listen to the end of this conversation, because we're going to share with you why perhaps at this stage in our life, for the first time maybe ever, we need to embark on thinking why we need a sexy book club. And I'm also going to share some recommendations with you of how you can bring a bit more of erotic stories into your life. I hope you enjoyed this conversation. It is all encompassing, and I can't wait for all of us to talk much more about sexual health. Laila, thank you for being here on a Saturday with me. Welcome to the Menopause and Cancer podcast. How are you?
I'm doing well. Thank you so much, Dani, for having me on.
And I feel like I owe everyone a quick explanation. We've been sitting here talking for half an hour, and I feel like you've really guided me on some of my responsibilities as a podcast host. So thank you for your time.
My pleasure. Thank you so much.
Laila, as an oncologist, I would love to talk to you about sexual health and the complications and the intricacies of sexual health. It's more than dry vaginas. Let's get the word out there as soon as we start the conversation. Talk to me about the complexity of this issue and also why you're interested in it quite a lot as an oncologist.
Yeah, absolutely. So I'm a medical oncologist and a breast cancer specialist, and I practice in Louisville, Kentucky, in the United States. And I see a lot of patients with breast cancer, and over time, I was realizing that I felt that I really was not equipped to answer their questions about sexual health concerns. And so, what I decided to do was to launch a special program, which is a sexual health clinic where any patient, any woman with cancer, can be referred to this clinic and be evaluated for sexual health concerns. And really, I felt like this was so important because in cancer care, there's so many treatments, so many changes that happen that impact sexual health. However, it's almost never addressed, or it's very infrequently addressed. And the result is many women are dealing with these symptoms silently, or it's majorly impacting them, even pain or relationship concerns, or impacting mental health, and it's not talked about. And so, through developing this clinic, I have learned a lot through working with organizations like ISHWISH, the International Society for the Study of Women's Sexual Health, and others. And I want to help to promote that conversation so that women with cancer know that sexual health concerns are common, they're important, and there are actually many treatment options available, and many different ways that things can improve. And so because of that, I actually turned to Instagram and other social media to sort of start this conversation or really contribute to this conversation. There's many that were already talking about this, and really try to help patients understand there are a lot of things out there that can help, and also to help medical professionals be able to more easily have those conversations. Because the reality is that, and you've talked to many medical professionals through this work, we are not really taught in our training how to assess this, how to diagnose, and how to treat sexual health concerns for women. And so this is a huge gap and a huge unmet need. And so thank you so much for the work you're doing on this podcast and with your organization to sort of bring this information to people who need it.
And so, Laila, it's more than just because a cancer treatment puts us into the menopause, and that's why we struggle with sexual health issues. What other factors contribute to our real need for having to have help with sexual health issues?
So when it comes to sexual health, I look at this through what's called a biopsychosocial lens. So what that means is when it comes to sexuality, there's biological factors or physical things, there's psychological factors or mental, emotional issues, and then there's interpersonal or relationship, societal messaging, and all of that comes together to impact a person's experience of sexuality. And when someone's diagnosed with cancer and goes through cancer treatment, all of those domains can be impacted. There's so many physical changes. There's so many mental and emotional changes that happen. And then if someone has a partner, that partner is experiencing their own set of, emotional, mental life changes as well, seeing their partner go through this treatment and the impact that it has on them. And so really, as you said in the beginning, this is not just about vaginal dryness. That's one component, but it is not everything at all. And so when I'm seeing somebody in my clinic for a sexual health concern, we sort of try to talk through this whole spectrum of biopsychosocial concerns, find out what's going on in each of these areas and what can be done to help it.
And we're going to go into all of the nitty gritty of exactly what can be done. And I want this to be a really action packed episode. So I hope everyone at home has got pen and paper ready. At the moment, do women and your patients bring this up with you, or do you bring the conversation up? How does it roll in clinic? Hey, thanks for watching this episode. 73% of people who watch my podcast haven't yet clicked the subscribe button, and 11% haven't hit the button to turn on notifications. I want these conversations to reach as many women as possible who might need to hear them. So if you've ever enjoyed listening to this podcast, please hit subscribe now.
So really from the literature and data that's been reported on it is known that even if a woman is having a sexual health concern, there is a very low rate of bringing that up. And that creates a huge disconnect because the medical professional, if they don't ask about it, which it's my strong belief that it is our job to ask about it, but the reality is that's not happening. They may then assume, oh, well, if the patient didn't say anything, then she doesn't have any problems. She didn't tell me about anything. And then the patient might be feeling like, oh gosh, I don't want to. Honestly, one of the reported issues is the patient doesn't want to make the doctor feel uncomfortable, which is really heartbreaking because we're here to help our patients. So when I'm talking to medical professionals about this, I really stress the importance of we need to be the ones to open this conversation and bring it up. We need to be able to say that, number one, sexual health issues can arise as a consequence of the cancer treatment. So just when we counsel about all other side effects or, these things could happen, we need to be talking about the impact on sexual health. And that may not always be happening. Number two, we need to establish that we can talk about this in the clinic. This is the right place to talk about it. This is a medical issue and we can address it, and that we're comfortable talking about it. And so I believe that it's really as medical professionals, our responsibility to ask all of our patients about any concerns about sexual health. But the reality is that that's really not happening. And so there's ways that patients can bring up those concerns to their doctors and their medical teams. And I hear a lot like, oh gosh, that would be really awkward, or how do I start this conversation? And so a couple tips I have for that. Number one is to write down your questions, because then you have it and you can say, I have a list of questions, and go through them. Number two, if someone feels uncomfortable, it's always a great idea to have a support person with them who can sort of, be there as emotional support, or also say, we have some questions about, sexual health, or could you tell us more about this? Number three, and this is something that many centers have, is they have through the medical record system a way to message the teams back and forth. So I suggest that before an upcoming appointment to message in and say, I'm experiencing these symptoms and I'd like to talk about it at my visit, because then your medical team has the opportunity to be prepared to answer those questions for you. So, although ideally the medical teams are asking these questions, if not, there's a couple tricks and sort of tools like using the my chart feature or other emailing feature to the medical teams to say, I want to talk about this and put that feeler out.
It's much easier sometimes to write it down because you're a step removed almost, isn't it? It's much easier than saying this is what I'm experiencing right now in words. Written messages can be so helpful. There is a lot to unpack, and I'm just trying to figure out where to start. Where do we start as patients? So if this is, I just remember myself, for example, I had no trust in my body when I was going through active cancer treatment. I was so worried what my side effects would mean. Would they get worse? So I had lost that trust. And without that trust, it is very hard to be intimate. What comes first often? Is it the emotional implications of a cancer treatment and a diagnosis, or are the physical symptoms sort of the driving factor and then the emotions come second? Is there a way of how it works, or is it very different for each patient?
So what I have found is that it is often very different for each patient. Number one, what the symptoms that they're experiencing are and how they affect them. And number two, what is of greatest importance or greatest precedence. So when I work through it, I usually do start with the physical issues. One common physical symptom that people experience is vaginal dryness, decreased lubrication, decreased elasticity, and others. So that is termed genitourinary syndrome of menopause, and it can come from the lowering of the estrogen. So if someone is premenopausal and undergoes chemotherapy, the result of the chemo can induce a menopause. And so someone even without any endocrine therapy, hormone blocking or lowering medications may experience this genitourinary syndrome of menopause. It's something that also happens with natural menopause as well. And then for people who have breast cancer and are on treatments like tamoxifen or aromatase inhibitor, which further block or lower estrogen, they might have a worsening of that syndrome. So this includes urinary frequency, urgency, burning of the vulva, discomfort when people wipe, irritation with wearing certain clothes or sitting in certain positions or riding a bike even. All of these are things my patients have told me. And vaginal dryness, decreased lubrication, and also eventually the sort of the elasticity can be affected too. So all of that falls under genitourinary syndrome of menopause. And so that is one possible physical symptom that can be there. So that can be addressed with a variety of different treatments. So if someone has a hormone receptor positive breast cancer, then many guidelines, including ASCO, the American Society of Clinical Oncology, recommend to start with a non-hormonal treatment. And so that would be in the form of a vulvovaginal moisturizer. So these products are available over the counter and they don't require a prescription. And there's really a range of products. And these are intended to be used on a regular basis for the health of the tissue. So this is really important for people whether or not they're sexually active, because it's important to keep that tissue healthy regardless of sexual activity. And so a non-hormonal moisturizer, there's really a range all the way from some people use natural oil products like coconut oil or olive oil. Other people will use a over-the-counter moisturizer. And then the products that I recommend most often actually have a component in it called hyaluronic acid. And this is something that draws in more moisture. It's been common in cosmetics and face creams and things like that for moisturizing properties. And there are several brands that incorporate hyaluronic acid into a non-hormonal moisturizer. So this can be used 3 to 5 times a week, or even every day on the vulva and on the vagina to provide moisture. So because the body isn't producing it, it's replacing it. So they only work as long as they're being used, and they need to be used on a regular basis. And they come into, oh, go ahead.
Sorry, we have these lovely conversations with some of the women in our community, and we often say, gosh, when did it change for us that we now need to treat our vaginas like our best cashmere jumpers, treat them with the utmost care, or you almost need to moisturize your vagina like you moisturize your face. And there comes the time where this is becoming part of your daily sort of regime. However, here in the UK, we have a lot of brands that contain really irritating ingredients, and women often don't know. And I don't know if it's the same in the States, but actually some of our general practitioners can prescribe vaginal moisturizers that are really not very good for us. And so we don't, here in the UK, have loads of brands that are safe ingredient moisturizers and lubrications. So it's important to do a bit of research there, isn't it? I will list the good ones we have in the UK into the show notes. They're Yes Organics and Sutil. Maybe you can recommend a couple for America. I don't know if our American
so the
audience...
brands I usually recommend are, one is called Good Clean Love, and they have different products, including a moisturizer with hyaluronic acid. And some products come in the form of a gel that can be applied with the fingers. And then other products come in the form of a suppository. So it's sort of an oil-based solid suppository that can be inserted into the vagina. So one brand called Hyalogine and another one called Reverie make really nice products with hyaluronic acid. And then the brand you mentioned, Yes, is excellent with very, very, probably one of the cleanest ingredients that I've come across. So it's very important to be really discerning about the product used, because if it has if it has a lot of additives or other irritating chemicals or scents or things like that, it can be extremely irritating and actually worsen the situation.
And we know from data that such a high percentage of people with a history of cancer who are pushed into the menopause struggle with all of the symptoms you have just mentioned. Wouldn't it be just making so much sense if every cancer patient was walking away with a few samples of a vaginal moisturizer and we said, actually, get on that ASAP, because the chances that you will struggle are there. Why wait? I never sort of understand.
Yeah, I think that would be great. And as a medical professional in the US, I do have the ability through my office. We request samples. So actually, I used to have this huge basket of moisturizers and lubricants in my office, just like overflowing, and it's completely empty now because we've given out all those samples. And so medical professionals can request samples to be sent to their office to hand out. And so let's see,
It's like going for trick or treat to Dr. Laila Agrawal's office. You get vagina moisturizers instead of sweets.
Yes. So, they do give samples to offices. So this way I can provide patients. And I think it's a really great tool because it really says, this is so normal that I literally have a bucket of this in my office to give to patients. Yeah. So these are samples of the vaginal moisturizer with hyaluronic acid. And then here is an example of the suppository that I was talking about. And so this is a solid oil-based moisturizer that can be inserted into the vagina, melts with the body temperature. And there's other products that are like that too. But absolutely, I think having samples and really knowing upfront before the problem has developed that you now have a new component of your skincare, and it's your vulva and your vagina.
Yeah. You just mentioned that this is the recommendation for breast cancer survivors to start with non-hormonal moisturizers. But surely anyone who experiences a surgically onset menopause, for example, after other cancers, surely they struggle just the same. Is it also important to start with moisturizers before you start hormonal vaginal options?
So the guidelines I referenced, that is for a hormone sensitive cancer. So some breast cancers are hormone sensitive, other breast cancers are not. And then there's other types of cancer other than breast cancer that are considered hormone sensitive as well. But for someone who's diagnosed with a type of cancer that is not hormone sensitive, the best treatment is a local topical hormone. And so there's a range of options for that. So that would be, for example, an an estrogen cream, an estrogen suppository, or there are other hormones that can also be used, for example, DHEA. And so those are really getting at the root of the problem. So the reason why this syndrome of genitourinary syndrome of menopause has developed, and that's the low estrogen and other hormones. And these products are delivered locally. So that means they're not meant to be absorbed into the body and have effects on the entire body. Their main action is meant to be on the tissue where it's applied, which is sometimes the vulva and the vagina. And it's possible that a tiny amount may be absorbed, which is why the recommendation to start with a non-hormonal. And we can talk about that in a little bit about patients who have breast cancer that is hormone sensitive. But for people who are having symptoms with dryness of the vulva as well as the vagina, a cream product is really helpful because that can be applied to all of that tissue. And then others prefer a suppository. I mean, there's many different ways they can be delivered, and people will have different preferences. But use of topical vaginal hormones is really the best treatment for this.
So on your social media, I saw that you were going to put together a bit of a survey for all of the breast cancer patients or cancer patients that are sort of in your realm, and you wanted to know about their struggles and their worries and about their treatment. Do you know the answers yet to the outcome of that?
Yes. So
Yeah.
with two other amazing physicians, Dr. Corinne Men, who's a OBGYN, and Dr. Eleonora Toplinski, who's a medical oncologist, the three of us put together a survey for people who had been diagnosed with breast cancer, trying to understand what was their experience with getting information about sexual health concerns. Because from everything that we have heard, our own experiences, we suspected that the chance of getting information from their medical team would be quite low, and that some of that information might not be correct. And so we put out a survey, and we got an overwhelming number of responses. We were just floored, blown away by the response to that survey. And we do know the results, but we can't reveal them just yet.
Well, you just have to come back on and tell us.
Yes.
Because I wonder how many people know who've had an estrogen receptor positive breast cancer, what their options are around vaginal estrogen. Tell me, because on your social media, you seem very confident that it's a very good option. How many people know that? And tell us what the recommendations, the guidance in America is. What society do you take your information from? And what can we share with people so that they can take that to their practitioner? Because not everyone obviously has an amazing doctor like you. And I think some people listening to this conversation might have to educate their doctors a little bit along the way.
Sure. So let's talk about the use of vaginal estrogen in people diagnosed with a hormone sensitive breast cancer. So this would be an estrogen receptor, progesterone receptor positive breast cancer. And they might be on treatment with tamoxifen, which is an antagonist or a blocker to estrogen in certain tissues. Or they might be on an aromatase inhibitor, which lowers the estrogen production in the body. And so they're being told, we're blocking or lowering estrogen. You shouldn't ever take any estrogen because we're trying to do the opposite. But meanwhile, they might be having really severe symptoms with vaginal dryness, pain, urinary symptoms, all of that. And so we know vaginal estrogen is an extremely effective treatment for that. But the question is can this be safely recommended to patients? And so thankfully, many societies, several medical societies, have put out statements regarding this exact question. And one of them is ASCO, which is the American Society of Clinical Oncology, which is our major oncology society. And this was in 2017 or 2018, so this is not new. But the statement says that the topical hormones can be used after discussion of risks and benefits. And essentially, the similar thing is said by ACOG, which is the Gynecology Society, as well as the Menopause Society, and they had a joint statement with ISHWISH, the International Society for Study of Women's Sexual Health. So this is a guideline-supported comment that people with hormone-positive breast cancer can use vaginal hormones after discussion of risks and benefits. So if anybody is told you can't have it, then that is not supported by the guidelines. The guidelines say, let's talk about what we know, what we don't know, what are the potential risks, what are the potential benefits, and let's make a decision together in shared decision making. So I think that's really important to know, that it is an option, and that women with hormone positive breast cancer, they can use vaginal estrogen after understanding what we know about it, what we don't, and what are the risks and benefits. So at the time when those guideline statements came out, the amount of information known about it was not very extensive. But since then, in the past year, there have been, I would say, 3 larger scale retrospective, meaning looking back in time at what happened, and evaluating the use of vaginal estrogen. So one of them recently came out and was looking specifically at mortality. So mortality is the chance of dying of breast cancer specific mortality. And they had a large database, 2 large national databases. So they found the patients who had breast cancer and then tracked who was given a prescription for vaginal hormone. They were able to say who had a hormone positive breast cancer, and they also were able to see who was on even aromatase inhibitors. And what they reported was use of vaginal estrogen did not worsen breast cancer mortality, meaning if people use it, there is not going to be a higher risk of dying of breast cancer. And that held true for estrogen positive breast cancer as well as people who were on aromatase inhibitors. So that's a really important fact to know, that this study did not show increased breast cancer specific mortality. But a lot of people want to know about recurrence, not only mortality. So another study that was done through the US looked at a large network where they were able to say who had breast cancer, who got a prescription for vaginal estrogen, and then kind of track markers of recurrence, like did they have to have chemo again or surgery or things like that. And what they found was in the entire population, out of the women who used vaginal estrogen, in total, there was no increased risk of cancer recurrence, is what they concluded. But then they went in and tried to piece apart, okay, what about those who had estrogen receptor positive? And the truth is, in my opinion, this study was a little bit limited because they didn't have the information on all of the patients about estrogen receptor status. But out of the ones where they did know estrogen receptor was positive, there was no increased risk of cancer recurrence. Then they went a little deeper and they said, what about people who were taking aromatase inhibitor and vaginal estrogen at the same time? And you have to understand, they had, almost 40,000 patients in it. And out of all of those patients, the ones who used vaginal estrogen and then the ones who were on endocrine therapy with an aromatase inhibitor and vaginal estrogen at the same time was minuscule. It was about less than 100 patients that they found, but they did report an increased risk of cancer recurrence in people on an aromatase inhibitor who used vaginal estrogen. I think that data is very limited because of the numbers, as well as I think they were missing huge chunks of information just based on what they could extract. So I think the top line conclusions are important, but I don't think it gives a lot of useful information on that question about what about if you're on an aromatase inhibitor and vaginal estrogen at the same time. So many people want to know, I had breast cancer 5 years ago and I'm not on endocrine therapy anymore. Can I use a vaginal estrogen now? And I think these 2 studies really include somebody like that and can really answer the question there. Another study was done the year before, and it was called a Danish observational cohort study. And this similarly looked at a group of people with breast cancer and then figured out who was taking vaginal estrogen and who was taking tamoxifen or an aromatase inhibitor. And this was really older data, so it's limited in the fact that they didn't check HER2 status, which now is a huge component of cancer care. And also that the doses of vaginal estrogen that they used were higher than what we have available today. But that study found overall, vaginal estrogen use was not associated with higher chance of recurrence. In people on tamoxifen, it was not associated with a higher chance of cancer recurrence. In people who were on aromatase inhibitors and vaginal estrogen at the same time, they did report a higher risk of cancer recurrence. However, it's important to note that the way that they measured the underlying risk was not the way we do today, because we factor in HER2, and that those patients might have been using higher doses that have higher systemic absorption as well. So that's what the data shows. It's limited, but it does provide some information there. So when we say discuss risks and benefits, that's what we're talking about. What do we know? What do we not know? How does the person feel about it? How are the symptoms affecting them? And what's sort of the comfort level with doing this? And so I do prescribe, vaginal estrogen for my patients who are having these symptoms. We have these conversations, even on aromatase inhibitors. So that's my practice.
And we're going to link to one great resource for all of our US patients. And I'm going to link to a conclusion here from one of our UK doctors about vaginal estrogen. And then wherever people are in the world, they can hopefully take that to their own consultants and to their own doctors and have their own conversations. So we talked about moisturizers. We talked about vaginal estrogens. Tell me more about the dilators, because I feel like they're often not that spoken about. I love that you are here. It means so much to me and my whole team behind this show. We released this show for free to help people like you learn more about this often misunderstood topic. And because so many of us feel totally under-supported going through all of this. In return, all I ask is that you help me on my mission by hitting the subscribe button and clicking the button to turn on notifications. It really helps a lot. Thank you. And now on with the show.
One very common symptom that people will have is pain or discomfort with intercourse, especially penetration. And many times that pain is due to dryness, which we've been talking about. And people might describe that as dryness, friction, or even like razor blades or glass shards or sandpaper. Those are the words I hear from my patients. And so if that's the symptom, then using the moisturizers, perhaps talking about a vaginal estrogen or other hormone locally delivered product, and the use of a really good lubricant is really important. And so for some people who are having a lot of dryness, using a product called a silicone-based lubricant might give more lubrication, be more slippery, and be longer lasting compared to a water-based product. But for other patients, that's not it. Or maybe they've done all that. They clearly can tell the dryness is better, but there is still pain. And the pain can be more internal. So there's a couple things that can happen. One is that the tissue of the vagina can become less elastic, and so there might be discomfort. And the other thing is that the pelvic muscles that support the base of the pelvic area and the organs, those muscles can become what's called dysfunctional, meaning they can either be too tight and almost spastic, or they might not be working together, or they might spasm or tighten in response to penetration. And so one of the tools that can be used to help with both of those symptoms is a vaginal dilator. So a vaginal dilator, I have some here. A vaginal dilator is a cylindrical device that is meant to be inserted into the vagina to help with some of these symptoms. And really very often I recommend for my patients to work with a pelvic floor physical therapist to know exactly what is going on with their pelvic floor and what is the right exercise or the right treatment for them. So a dilator helps with two things. It can slightly help to, expand the tissue, but even more so, it can help a person be able to be in control of vaginal penetration, and can also help with the pelvic floor musculature, helping to learn how to relax those muscles. Again, I want to stress that every person's situation might be different. And so I always try to recommend for my patients to see a pelvic floor physical therapist to have a more personalized treatment plan for them. If someone's using a dilator, what they can do is basically have a really ample amount of a lubricant, and then the dilator can be inserted into the vagina to the level of comfort. So it's not meant to be painful or uncomfortable. And then when it's inserted, just to the level where it's still comfortable, to focus on breathing and trying to imagine like releasing the pelvic floor muscles. And as that becomes more comfortable, then there can be further insertion. And this can be done for really recommendations range, but for 5 to 10 minutes, 2 to 3 times a week. So there's no standard set amount. So it's not a huge time commitment, but it is certainly a time commitment. And then over time, these dilators come in sets. And as it becomes more comfortable, can move up to higher sizes that are a larger caliber as well as length. And then pelvic floor therapists, they can help with many different issues that arise in the pelvic floor. This can help not only pain with penetration, but it can also help with urinary issues like urgency, frequency, incontinence, and it can help with bowel movement problems as well. For example, if there's retention or constipation. So this affects a lot of different things.
I mean, we had a workshop not that long ago, and there weren't that many people. I think there was 25 amazing humans, and 2 of them said, I haven't had sex in years, Danny, because every time upon intercourse, I bleed. And it's upsetting, and it shocks both of us. It shocks my partner and myself. And ever since a couple of occasions, we just haven't even gone there. And that clearly means these patients had no treatment, right? They did not have the adequate treatment to help them with those symptoms. However, on the other hand, I look at you showing us the dilator right here, right now, and I think, gosh, when you have pain, of course, you're not going to want to have sex, right? Wanting to have sex means you're comfortable in your body. It means you are going to embark on something joyful that benefits you. And so we're not going to want to do that if we experience pain. Having dilators, of course, women want intercourse, but when we all think how women function and that the majority of women don't climax actually through intercourse and through penetration as such, it makes me think, are these dilators? Who are they for? I'm sorry, it's just...
Yeah, for sure. So, but, I think that the important thing to understand is if anybody is having bleeding, that is something that needs to be checked by their doctors, because bleeding could be a sign of, something going on. So with bleeding, talking to the gynecologist, making sure there's an exam, that there's nothing of concern that could be triggering the bleeding. And then that would also be a good place to say, okay, why is this bleeding happening? Is it because of, genitourinary syndrome of menopause? Is there is there something else going on, so that can be evaluated and properly treated? Yeah. And, for many patients, their goal is not to have penetrative intercourse. And that's, really important to know what your goals are. There's other reasons why an individual might benefit from these, even if that's not the goal. And so, for example, some people who may have gynecological cancers, a medical pelvic exam might be a component of checking for cancer recurrence. So even if penetrative intercourse isn't the goal, there might be other reasons why that may be helpful in terms of cancer surveillance too. But, I think to your point, the majority of women will have orgasm through clitoral stimulation and not through penetration. But everybody has a different, goal in terms of what they want for their sexual life and their sexual health. And so, there's many different stages of where people are and what they want. And for some, vaginal penetration is not the goal. They don't really want that whatsoever. And I think in that vein, it's really important to understand we need to expand our definition of sex. And so this very narrow, like penis in vagina sex is just a sliver of what can be enjoyable. And it's also not the most likely thing for a woman to orgasm. So really kind of saying, I hear from my patients a lot, well, it hurts too much. I want to have sex, but I can't. And then like, well, there's more to sex than, penetration for sure. And just really embracing and expanding and exploring many different avenues, even if penetration is not the goal, can either lead or enhance a satisfying sex life. So I think that's a great point, but for many women, that is a desired part of sexual activity. And
going back to the starting point of our conversation is where I said, what comes first? Is it the emotional sort of symptoms that stop us from wanting to even have sex or feeling turned on? Or is it actually our physical symptoms? I don't think you can feel really up for it if you have pain, if you're worried that you might bleed, if you have dryness, itching, all of the other irritations that you were talking about. So we need to address those. But often these are being addressed. And then women say, Danny, it's the last thing on my mind. I feel I should be doing it because I'm in a relationship and there is this pressure. And many people say to me, my partner is great. There is no pressure, but I'm still feeling it. But I have no desire. You call it low libido. We call it no libido. And then it's really hard because many people, and myself included, for a long time thought actually there is hardly any help with that. I trust that you can help me with my vaginal dryness, with local vaginal estrogen, with moisturizers, but it feels harder to believe that you can help me with low libido. And I wonder whether many people at home sort of feel the same.
Mhm.
What do your patients tell you?
Yeah, so low libido, or as my patients say, zero libido, is a really common issue. And the next question I usually ask after that is, how do you feel about that? Because some people might feel, and I hear this a lot from many of my patients, I couldn't care less if I never have sex again, and it's just not anything I'm concerned about, interested in, doesn't bother me. And if it doesn't bother them, and their partner, they're on the same page, and it's not distressing to them as a unit, um, it's okay. If that's not a concern or a priority, that's fine. But for other people, they feel a deep sense of loss,
Yeah.
a feeling that this was really important to me and to us as a couple, and it's gone. And they mourn that, and it's very distressing. Or they feel like they're okay, but they're still in this relationship. It's important to their partner. How do they want to do it for their partner because they love them, and that's important to them. And so there's many, many, many different ways that people might feel about this. And so, there's not a one size fits all. Every person and every relationship is going to navigate this differently. But a couple things that I sort of talk about. So first of all, this is a really common thing, and it is caused by a multitude of different issues, including hormones. So, if someone's premenopausal and they go into a chemo-induced menopause, it will affect libido potentially. Same with the hormone lowering or blocking medications can cause, a major change in desire, libido. And then many of the other medicines that may be prescribed along the course of cancer treatment, such as antidepressant medications or pain medications or antihistamine medications, and many others, can actually negatively impact libido too. So first of all, I think just looking through the medication list and seeing, okay, are these all the right medications? If this is a concern, are these the best medicines for me to be on? And sometimes they might be, and other times a switch or a change could be made. The next thing is kind of understanding that libido or desire comes in two different flavors. So one is spontaneous, that urge or natural desire to have sex, and the other is called responsive or reactive. And that's a very, normal type of libido that also, that even without cancer, those levels and the type of libido a woman experiences change over time as well, change over the course of a relationship as well. So there's many physical, mental, emotional, and relationship factors that all come together and influence libido. But I think that, I say this in order to kind of explain that an individual does have some control or choices about how they view it, the mindset, and also how they plan ahead for sex. So with responsive desire, there's some kind of stimulus that wakes up the sexual response cycle. And that might be a physical arousal, that might be a mental arousal through fantasy or watching something or reading something or thinking about something or being with your partner. It might be a desire for an emotional closeness with a partner. So many different things can kind of feed to the feeling of arousal, mental or physical arousal. And then the desire comes secondarily. So for people who have felt a sudden loss or even complete loss of the spontaneous desire, it's still possible to work with that sexual
Mm-hmm.
response cycle to enhance things that help with arousal that will then lead to the desire to have sex. And, you know, everybody's different in terms of what can help with that arousal. But for many, reading, sexy stories can help, or certain novels, or foreplay, or physical affection with their partner, or emotional connection with their partner. So making sure that all of those elements are sort of set up for success. And then the next thing is scheduling time for intimacy. And so, this is something where I encourage people, if this is their goal, to have more time for intimacy with their partner, to set a time and date ahead of time, like a week or several days ahead of time. Pick a time of day where you're, set up for success. So where energy is going to be the best. So a lot of times at the end of the day or at the end of a long week, people are just completely zapped of energy, and that's really the last thing on their mind. So kind of planning, okay, when will we have privacy? When will we have um, when will my energy be best, and then planning ahead for that. And the good thing about planning is that it allows building some anticipation, so you can kind of look forward to it, or start to send some messages back and forth, and kind of have that build up. Just like when people are first dating, they set a date and they have anticipation building up to it, and that contributes to the enjoyment there. And then, to understand that there doesn't need to be a particular goal in mind, and it can just be an experience of shared connection and pleasure. And so, what I hear from my patients is that there can be a real sense of frustration of, you know, um, this is what I was expecting, and and it didn't happen, and then I got really frustrated, and then kind of in your head about why is my body not responding the way it did before, and feeling negative about that. So really to just sort of try as much as possible to remove goals or remove expectations, and look at it as an opportunity for connection and for pleasure, and however that would look. So those are kind of along the lines of just little small mindset changes, and maybe small um, behavior planning changes. And
Mm.
for many that helps, that helps, but it's not the whole
Mm.
thing. And so beyond
Mm.
that, desire, libido is really a very, I mean, it is truly a biopsychosocial thing. So there's
Yeah.
physical, but then there's also a huge component of mental and emotional factor that goes into it. And truly working with a counselor, or with a sex therapist, can be very helpful in understanding and improving libido. And that can be
Mm.
done as an individual or as a couple, whatever felt right at that time.
It's just so interesting, isn't it? Because I think many people, when cancer comes along, you just don't expect it. No one does. And then we expect there to be certain changes, like people expect to perhaps lose their hair if they embark on chemotherapy. They expect that perhaps surgical menopause would make the menopausal, and that's it. There's no way back. But certain things we expect to continue and not change. And so many women say to me, I just didn't think that our sex life was going to become so different, or I would feel so different about it, or that I would absolutely, like you said, have zero desire to embark on any sexual relationships with my partner. And so we expect it to carry on and be the same, whereas it can't, because we have had so much prodding done, so much invasive treatment. We often have a very difficult physical body. We accumulate scars, we lose hair, we lose our body parts. It's an illusion to think that our sexuality can continue the same way, right? Something needs to change. It just makes sense when you look at it sort of from the outside. But when you're in it, you think, oh no, that's just going to carry on. But I think that's a hopeless thought, really.
That's exactly right. So many things are different. And one of the things you mentioned was loss of body parts. And if somebody is diagnosed with breast cancer, they may have a mastectomy surgery where the breast is removed. And even with reconstruction, most of the time sensation is either absent or very different. And for many women, breast stimulation is a huge part of their sexual pleasure and even orgasm. And after a mastectomy, that can be gone. And I think that some people don't expect that, or they don't realize that that's a part of it. So I think that um, in that situation, it's it's difficult to continue to try the same things and not have the same
Yeah.
results and feel frustrated. So it's almost like going back to square one and just rediscovering what is pleasurable to your body now, and that is something that um, people can do on their own, just to kind of learn, okay, what feels good now, what does not feel good now, or together with their partner. And there are certain techniques that can be done together with the guidance of a sex therapist or other counselor. For example, one called the sensate focus, which really is a way, I mean, this has been around for decades, and it's a way that the partners can sort of reconnect with, in simple terms, the sensations of touching their partner and of being touched. And it starts off with, no chest or genital touching, but maybe hand or hair or face. And then to just reconnect with, like, how does that feel? And what am I experiencing? And how does it feel to touch my partner, to be touched? And so there are established techniques of how, this mind body connection can kind of be reestablished. And so
Yeah.
those sorts of tools can be helpful for some people.
And you need to want to do that, right? Because it's another project. Because the one thing about managing menopause after cancer, it's like it gives you all these projects. And sometimes we haven't got the energy, we just want it sorted. And then you think, gosh, I have to do all of these things to get back to maybe a sex life to where I was before all of this. But it's just the way it is, isn't it? You've got to put the effort in. And sometimes that just feels a little bit too much and then nothing happens, which is very normal as well, isn't it? I think.
Yeah, it is a lot. I mean, between now your exercise and your
Yeah.
nutrition and your rest and your lifting weights, and you're going to lymphedema appointments, and
Yeah.
maybe seeing a counselor and all this other thing, and then, gosh, when are you supposed to work and to have a family, and
Yeah.
you know
Yeah.
all the other things that happen. So I think that
Mm,
even though we're talking about so many different things, it's also
mm.
very practical to just pick one thing. Like, let's just do
Yeah.
one thing right now and
Yeah.
then maybe do
Yeah.
something else later.
Yeah. I wonder, do we tell men to put this much effort in after a cancer diagnosis? I have no idea. It's not on my sort of radar, but I do think we're expecting a lot from us. Like, I know patient participation is huge and we all strive for a better quality of life and we're talking about sexual health and it's so important to talk about it all. But sometimes I get to the end of the week and I think, gosh, it's all rather exhausting.
It's definitely, yeah, it's a lot.
Is there anything else in terms of sexual health that you have developed? Any other strategies that you've developed in your special clinic, helping your patients currently? Something we've missed maybe to address?
Well, another thing that's really important is the way people feel about their body image. So, body image has to do with the way that somebody feels and thinks about their body and themselves. And when there's a cancer diagnosis and treatment, there's so many changes that can happen to someone's body, both inside and out, that were not desired or wanted whatsoever. And many of them are completely unexpected. And then just sort of understanding how you feel in your own body and how that makes you, or really how you think about your body and how that makes you feel. And as a result, what are your behaviors and your actions? So um, I really see this a lot as something that can be extremely distressing to some individuals after
Yeah.
going through cancer treatment, whether it's weight changes or breast surgery or reconstruction or um, hair. Even if hair grows back, it's often completely different appearance than what it was before. And so,
Mm.
you know, that real disconnect between somebody's sense of self and what they see and experience with their body can be different. And that feeling of being comfortable and confident in your body is so tightly connected with how someone experiences sexuality. And so,
Yeah.
many times I hear that um, people feel really negative thoughts and feelings when they look at their body or look in the mirror after going through these major changes. And so I think that it's really important to understand that that can change with counseling or therapy or certain changes in mentality or mindset. And um, I think what I do see and hear a lot is that those feelings might be suppressed a little bit, thinking like, I shouldn't feel this way, or this is vain, or it's just hair. So people say it's just hair, but it's really of utmost importance. And if it's something that is causing a feeling of distress, then it should definitely be discussed, and that there are treatments, including counseling, that can help with that and help improve that. Because it would be hard to want to be in a sexual situation with a very distressing feeling about one's own body. So I think that's really important, and really deserves a lot of attention.
And I just think of all of our listeners that have stoma bags, for example, and some might not be able to be reversed. I know so many young cancer survivors that have huge scars, their whole tummies, really big scars. And I think it's almost, again, impossible to think that you can trust your body or trust others to see you for the beautiful being that you are when you really, really struggle with what's happened to you, because we all do. And often people say you've just got to accept who you are, because, you know, our scars are sort of telling the tales of how far we've come. And although that is true, it's also, I think, a little bit of that negative false positivity, because not everything can be spinned and given into that positive light. Sometimes it's okay to say, I did not want this, I did not ask for this, and I don't like it. And although I feel it's a real privilege to age, I have blow dried my hair this morning and I have much more grey hair than last week. And I thought, although I feel it's a real privilege to notice my grey hair, because when I was diagnosed, I didn't have grey hair, and it's amazing. I'm here to watch my grey hair. I don't have to like it, and I'm going to dye it. And I think both of those feelings can coexist.
Yeah, definitely. And I think that when, I mean, there's no one's asking anybody to like what's happening with the body, or
Yeah.
even to feel positive about it. But one thing
Yeah.
that could be a slight step forward is to
Yeah.
consider a neutral thought as opposed to a negative thought. So, you know, what I hear from my patients is often that if they look in the mirror or they look at, you know, their body, they might have an automatic negative thought, which is very understandable. But is it possible to instead think a neutral thought, not a positive thought, but just like a fact, just a statement of fact, and to see if that changes some of the feelings that the thought elicits? So that's sort of just, there's no reason to go from all the way here to toxic positivity, but is there a step that can be made that might feel slightly less distressing? So, you know, this is a process. This is going to be different for everybody, and certainly working with a counselor can really help with everybody's individual feelings on the topic. But, you know, one just small step would be just sort of thinking of something maybe neutral.
I love that. Gosh, it is complex, isn't it? Sexual health after cancer, or sexual health in general, actually, is really complex. Yes, I know you mentioned the declining estrogen levels, but there is so much more to it than just addressing our physical symptoms. It's really, really complex. And it's amazing you talk about it to all of your patients and you're so passionate about it, because I do really think it can significantly improve our overall feeling of how we're recovering, by starting to slowly tackle things. And it feels healing if you feel you have a little bit of agency over your sexual health, whether that's physical, emotional, in your relationship. Thank you, Laila.
Thank you.
Wow, I wonder what people are going to do with all of this amazing situation. And I hope they can do one thing that is what you have mentioned. And it's just doing one thing out of all of those amazing strategies you have mentioned to us. And that would be a great step forward, isn't it?
Mm-hmm.
Maybe look at the resources we have linked below in the show notes. Maybe go make a doctor's appointment. Maybe speak to your partner. Or maybe, I liked what you said, tune in. What did you say? Read a sexy book. I wonder, what sexy books can we share with one another? Do we come up with a sexy menopause and cancer book club? Have you got a sexy book, Laila?
I love that idea. Actually, what I recommend to my patients is an app that's online on the phone. It's called Rosie, and it's It's fantastic. It's created by a gynecologist. It has a lot of medical information for sexual health for women in general. But it
Mm.
also has a library section in it too, where it's got some sexy stories. And so I think for some people, they don't want to search online for that type of material. So it's nice to have a doctor recommended resource to find, something like that feels safer.
Will you share that with me?
Yeah,
I've just tried to Google
absolutely.
it, but I only get rosy apple sweets, and we don't want to
Meat, I
advertise
think it's called
those.
meat. Yeah, no applesauce. Meat
Exactly.
rosy. Yeah, I'll send it to you so you can link it in your show notes.
Great. If anyone wants to send us a message to Laila and myself with a sexy book recommendation, we're all here for you.
The book club we never knew we needed.
We're going to do it, Laila. We are going to do it. Thank you for your
Amazing.
time today. You're amazing.
Thank you so much, Danny. It's my pleasure to talk with you.
I hope you found this podcast recording with the fabulous Dr. Laila Agrawal as helpful and interesting as I did. And if you're unsure whether you're low libido or no libido or your physical symptoms, whatever needs addressing first, then maybe just do whatever is sort of in reach for you at this particular time. We can't tackle it all. We can't suddenly start talking about our sexuality within our partnerships, perhaps if we haven't done so for the last decades. But there is always something you can do within one of those modalities, whether that is within talking about it, whether that is maybe treating a physical symptom first, maybe that is starting to tune into some sexy stories. And in doing my research in what I wanted to share with you today, I've just gone onto the app that Dr. Laila Agrawal recommended, and I'm going to share that link with you. Struggling with low libido, looking to spice things up. Whatever your sexual health goals, Rose's 150 plus erotic stories put female desire center stage and will get you where you want to go. Now, maybe this is your starting point, and maybe for you, as for me, first time in your life, you're going to tune into a erotic story, and maybe that's going to just be your first step. Anyway, whatever it is, I hope the information here has been helpful, and let's keep talking about sexual health much, much more in the future too. Sending you lots of love, and I can't wait to talk to you again on next week's episode on the show.